Well, good afternoon, everyone. Welcome back. I hope that your coffee break was adequate for you. We've got an hour and a half now, an hour of 3 speakers, 20 minutes each. And then we've got half an hour for your questions, which you can put as before in the chat function. I'll try and collate them and we'll try to then let you drill down with the experts afterwards. And the theme this afternoon now is a little different from previously. We're looking at essentially young, fit, healthy people and how they respond in terms of long COVID and what can be done for them. So we've got 3 superb speakers dealing with military rehabilitation, athletic rehabilitation, so in athletes and their perspective, and then the issue of whether we can improve things by looking at rehabilitation through inspiratory muscle training. So first up is Oliver O'Sullivan, who works at the Ministry of Defence and has been dealing with military rehabilitation and recovery. So he's going to tell us a little bit about what he's learned. So Oliver, over to you.
Thank you very much. Thank you for the introduction and thank you very much for inviting me to talk today. Thank you all to the speakers earlier today. It's been fascinating. I must confess, normally virtual conferences, I don't listen very much, but I found today really engaging, and especially I enjoyed Mark and Anushka's talk first up, which I felt really centered the patient in the middle of this conference. So my name is Ollie O'Sullivan. I'm a specialty registrar in rehab and rheumatology, and for the last 2 years I've been heavily involved with the post-COVID services based primarily out of the Defence Medical Rehabilitation Centre at Stamford Hall. Pictures on the screen, it is genuinely beautiful, but we work across the Defence Medical Services. So I'm just going to give an overview of the last 2 years worth of rehab and recovery services and what we've done and what we've found. I've deliberately decided to go for breadth rather than depth. So my contact details are on this slide and they'll be on the final slide along with all the papers that I mentioned. So if anyone wants to get in touch afterwards, then do feel free. Obviously, any opinions stated are mine and not the official opinion of the MOD. So about this time 2 years ago, when the pandemic was really spreading across the world, we realized that we would be involved. There would be some call for some post-COVID services from Defence. We had this key question in our mind, which was how do we return young, physically active population to full health and full exercise at scale without risk? And we really wanted to avoid scenes that were potentially seen last summer with Christian Eriksen, and I'm really glad to see him back playing now. We had a team of 21 authors and we split up into 7 teams and we performed a quick, rapid review of the literature, looking at other post-viral syndromes, previous coronavirus epidemics, and early data from China, and drew together 36 recommendations, which we felt should be the center of post-COVID rehabilitation. This was the evidence base for Defence to build their strategy around. And I think 2 years later, what we felt was important is probably not a million miles off the mark. Defence as a collective instigated medical policy for a clinical occupational risk assessment prior to return of duty. We didn't know what would happen and we felt it was important to make sure that our personnel were safe. This is what it looked like. Excuse the busy slide, but essentially initial severity, ongoing persistent serious symptoms, and an inability to return to baseline were the things that would trigger a referral into primary care, where ECGs and exercise testing, we use the 1-minute harvest step test, and a clinical assessment would trigger either referral to the recovery service to exclude pathology or the rehabilitation service to look at improving symptoms and improving the care of the individual. These things ran concurrently because we felt that it was important to rehab people, even if we weren't sure what was going on. And as a rheumatologist and a rehabilitation specialist, I have this weird dichotomy where medically I'm really interested, but ultimately the patient care is really important as well. So the first thing you have to do when you think about rehabilitation, as you know, is assess the patient. So we developed a remote assessment tool, which went live in April of 2020. And I think that was the first tool in the UK to be used. We developed it using an experienced multidisciplinary team, experienced looking after post-viral syndromes, and we wanted to know the symptom burden, the impact on ADLs and occupation, and later we wanted to know, use it as a medical filter and see if people needed further assessment. When we performed a review after 7 months to make sure that our assumptions weren't too far off the mark, we looked at first the acute symptoms and then the post-acute symptoms, and we wanted to know the relationship with the test status because we pragmatically had gone for a clinical referral. So if you had symptoms consistent with post-viral, post-COVID syndrome, then we wanted to see you. We didn't want to wait for a positive test in the beginning. As you know, that was really difficult. And I'm glad that our plan was the correct one, because when we looked at it with test status, those people with no test or a negative test had worse symptoms and waited longer to see us. So the pragmatic approach we felt was the correct one. We found no correlation with acute severity, which is interestingly different to what some of the talks have said earlier. We're now performing a second review of the same tool. So we're going to compare the first wave to the second wave. And the initial assessment analysis of that seems to indicate there's some subtlety in symptoms difference. There's some prolonged waiting before specialist rehab is referred for, which suggests that primary care are more comfortable managing this problem. And there's an increase in mental health problems. And when we've looked at society as a whole, there's some association there. So that suggests that perhaps it's not just COVID that's causing all the problems. Having been assessed, we invited people who we felt needed it for rehabilitation. So approximately 60% of people were invited in for MDT rehab. This was a 2-week residential model with the kind of key building blocks on the slide, followed by a 3-month guided self-management, and then we followed them up at that point. The things that we looked at were kind of education, patient education is essential, and then some holistic management, sleep, nutrition, pacing, goal setting, and being aware of the psychological burden of this disease process. We looked at kind of well-being and mindfulness. Pulmonary rehabilitation we'll find out more about at the end of the final speaker in this session, but that was really important. And we used a symptom titrated activity approach. So initially in the gym, under medical and allied health professional guidance, using 75% heart rate, we started some low-level strength and conditioning, some low-level cardiovascular stuff, and then that in the 3 months afterwards was guided by the patient and how they felt. And if people needed to come back for subsequent rehabilitation, that was offered, but that was very small numbers. The average age of people was about 41, and 86% of those were male. 16% were female, and 16% were from a BAME background, and those are higher than the normal armed forces demographic, suggesting there was a slight increase in those. 30% were above target BMI, which in our population isn't always the most helpful measure, but it is consistent with a higher BMI giving you perhaps a higher risk of having post-COVID syndrome. So that's from a rehab point of view. Now, from a recovery point of view, we use that term to cover the services where we want to know, is there any organ pathology? Is there any medical problems? So we developed a cross-CADA collaborative service between general practice, occupational health, defence rehabilitation, and defence physicians to allow a medical and occupational assessment. Over a 2-week period, we would assess and conduct appropriate investigations and then present a management plan, including occupational guidance. And it would start and finish in primary care with the medical officer of that individual kind of being aware throughout the chain and then owning that process. This is what it looked like from a schematic point of view. So they'd come to the DMRC at Stamford Hall for 2 days, undergo those assessments. And then after an MDT discussion, those people who required secondary care investigations, such as CT chest, CTPA, cardiac MRI, and so on, were offered them. We used cardio pulmonary exercise testing as the cornerstone of our service. This is because a lot of the symptoms were exertional symptoms. So we wanted to see if they appeared at exertion. CPET, for those people who aren't aware, and I'm looking forward to Dr. Hall's talk in a moment, is good at identifying objective limitations and giving you some indicator about where to go next in terms of investigations. Is it heart related? Is it lung related? Is it a general deconditioning? Is there any abnormal breathing patterns? Things like that would then give you a cue to the appropriate investigations and management for that individual. We also had some objective cognitive testing, which allowed us to quantify the brain fog experienced by our patients, but also importantly, hear their voice and say, this is what our objective measure says. With your subjective symptoms, you are not making it up. They exist. There is something that we can see. So I realize this picture has been on 3 slides in a row. It's doing some pretty heavy lifting. I need to get some more. So when we looked at CPET as a device, when we did a review after 6 months of the service, we saw that the use of some basic CPET criteria can exclude significant disease. Obviously, those people who met the thresholds below underwent further investigations, and we could see with their cross-sectional imaging and further investigations if there were any significant pathology. And those people who did not meet those criteria, there was no significant pathology there. The sensitivity and specificity was increased when using point of care blood testing, capillary blood gas testing, but we realized that that's perhaps not accessible to everybody. When we performed a second review of all the patients who had gone through the service, to understand what were the kind of key problems that we needed to manage, 70% had multiple symptoms and were not at that pre-COVID baseline. There was a low incidence of organ pathology, but a high burden of symptoms. And when we performed screening for mental health problems, there was a significant proportion of people who met the criteria for referral. Those people who had high mental health burden and they failed to meet functional bars in their CPET and their 6-minute walk test had associations with the objective cognitive assessment. So we wonder whether there is some element here that contributes or is part of the mechanism. We can't describe the mechanism in the way that we heard earlier fantastically with some of our speakers, but we wonder whether there's a contribution here. Another element of mechanism that's been talked about a lot is dysautonomia. So we looked at that and we used Jovan's criteria. So resting heart rate increase with exercise and a heart rate recovery post cessation of exercise. And we found that 25% of people met the criteria used by Jovan. Interestingly, they were not associated with symptoms or subjective limitation, but they were associated with objective limitations, which again suggests dysautonomia contributes to, but is not the sole cause of post-COVID syndrome. We found that there was increased ventilatory inefficiency, and we couldn't really explain that. Obviously, the 2 main causes would be some lung pathology or some abnormal breathing pattern. So we looked at the cross-sectional imaging, the spirometry, the gas transfer, and couldn't find a lung pathology link. But we saw that there was increased breathing frequency at rest and the anaerobic threshold. So we wondered, perhaps, is there a central cause that leads to dysautonomia and breathing inefficiency? So those things have described what we've seen in the clinical cohort at moments in time. But what we wanted to know is how do people change over time? So we designed and set up the COVID study, which is a 4-cohort study looking at people hospitalized, those who had mild to moderate COVID who stayed in the community and have ongoing symptoms, those who stayed at home in the community and are recovered, and a control population who did not have COVID confirmed with antibody testing. Primary secondary outcomes measures are on the screen, and we looked at them at baseline, which was a median of 5 months post-illness, aiming to follow them up at 6 months and again at 12 months to see how over time the groups change. The first paper is under peer review. It's also available as a preprint on Research Square. And this is the baseline characteristics. So at the point of recruitment, we recruited between August 20 and August 21, finished recruitment at that point, and the study is due to finish August this year. We recruited 113 participants across the 4 groups. And what we found is those who were hospitalized and who have ongoing symptoms, who are in the community, were generally older, had a higher BMI, worse mental health outcomes, and worse exercise testing, both sub and maximal tests. Incredibly significantly, we found those people who had mild to moderate illness who stayed in the community were no different to controls in any parameter. So this is fantastic news for defence, and we hope for the broader research community. If you had mild to moderate disease and you feel better, our study would suggest you are better. So that's incredibly reassuring, because that is the vast majority of people who have had COVID. When we looked at the data in a slightly different way, when we looked at recovery status as the variable, those people who are hospitalized and now feel recovered are not back to the same level. So there is, we think, an element of initial severity as well as ongoing symptomology that contributes to the post-COVID syndrome. I am a small cog in a very big wheel. I only have one shelf behind me, not a whole bookcase. On the screen are the core of people who have been working with me over the last couple of years, but there are many, many military and civilian collaborators across the Defence Medical Services and across the NHS that have contributed to this work, both the rehabilitation, the recovery, and the research. In summary, we've gone through an awful lot. We've seen approximately 700 personnel across all flavours. About 400 needed rehab, about 300 needed DCRS. Some people needed both. There was a low incidence of cardiopulmonary disease, regardless of the initial severity. Those who were hospitalised were more likely to have problems on imaging, but there was a very high symptom burden. Some people still not recovered at 6 months or beyond, but most people are recovering, and the majority improve with support. The main problems are fatigue, working memory, which perhaps may only appear under stress, and that's something to be mindful of when we have people doing critical tasks. High prevalence of mental health issues, multifactorial, we think, and perhaps some elements of COVID, some elements of general society, and some other elements. We feel that MDT rehab is essential for those people that need it. It makes a difference. And as I say, the M-COVID study allows longitudinal assessment, and it's due to complete in the summer. There's lots more work coming out. The wave comparison that I mentioned, the recovery status work, the 6-month data is just about to be analysed. We finished our 6-month follow-up visits a couple of weeks ago. Incredibly exciting. And we've got a lot of cardiologists working with us who are looking at echocardiograms, gadolinium imaging on cardiac MRI, and with dobutamine, aiming to understand what cardiac changes have happened. And we've got a team of neurologists that are looking at MRI scanning, neurofilaments, and aiming to tie those in with the objective cognitive assessment to try and get a clearer picture of what exactly this brain fog is. And finally, as I said, recovery, rehab, and research is a team sport. And thank you again to all the people who have collaborated over the last couple of years. If you're interested or struggling to sleep at night, on the screen are the papers that are in print or in peer review, and my details are at the bottom. So as I say, if you wish to ask any further questions, please do get in contact. Thank you for listening.
Oliver, that was fantastic. Thank you very much. A tour de force, and in under time as well, which is highly efficient. I'm not going to monopolize questioning now, because I have got lots of questions for you, actually, because I thought that was a really interesting and stimulating talk. But let's save them because we're going to do those in 40 minutes. So without further ado, let's move forward from the military athlete, as it were, to athletes more generally. And James Hull a friend and colleague who works at Royal Brompton, has been leading work really in rehabilitation for long COVID in the athlete population. So James, tell us what you've learned and what you think we should learn from you.
Well, thanks very much, Hugh, and to the organising committee. I just want to double check you can see my slides okay.
Yeah, that's terrific. Thank you.
Perfect. Okay. So listen, over the course of this next 20 minutes, I just want to, as Hugh introduced there, discuss what we've learnt about COVID in athletic populations, right from people who are simply recreationally active right up to the very elite level. And I'm going to share some data on Team GB athletes as they were preparing for the Olympics and Paralympic Games. So I'm going to cover three areas. First of all, what do we know about COVID, the illness? I'm not going to talk about SARS-CoV-2 asymptomatic infection and how it impacts athletes. What do we know about the features of COVID, and particularly the characteristics of prolonged recovery? And by that, I not only mean symptoms, but also impact on being fully signed off and back to sport. And of course, what do we still need to learn, which is an awful lot. So I'm going to take you back to the very beginning of the pandemic, a scary time I'm sure you all remember, where we didn't really have much insight in terms of what this illness could do or cause. And I suppose over the course of the first few months of the pandemic, it became apparent that this was really a disease which caused its most devastating impact in individuals over the age of 40 and potentially in those with other comorbid conditions. And specialists right across the globe were obviously very interested in their own specific cohorts. How did this affect, for instance, patients with cystic fibrosis or diabetes or rheumatological disorders? And myself and some others thought it would be remiss of us not to really consider how it might be that athletes would be affected by COVID. And as you can imagine, when we wrote this editorial quite early on in the pandemic, it was a delicate balance to be found between arguing the case for athletically fit individuals who might be affected by the fact they weren't going to be able to compete in the Olympic Games, against the fact that many people were still obviously very sadly succumbing to this illness, and ITUs around the globe were full of patients suffering with the long-term influences and impact of this condition. But within this article, we started to put together some of the considerations of how COVID might cause challenges for athletes. And for the first time, we put together some recommendations about how you might avoid partaking in sport after COVID. And we plucked from the sky this figure of 10 days of no sport and then 7 days free of symptoms. The pandemic until recently. And I raised that not just to suggest that we were the first to produce it, but to really contextualize why it might be that some of the recovery times are slightly more prolonged than you would expect in people who are otherwise asymptomatic in some of the data I'll share a bit later on. Now, about the same time, others were thinking about whether physical activity might be influential in terms of the development of complications of COVID. And here's Mark Hamer from the ICH at UCL. And he was probably the first to publish an epidemiological study which showed that individuals who were physically inactive or weren't doing sufficient activity were associated or appeared to have a higher risk of hospitalization for COVID. And as he shared on his Twitter at the time, which is my go-to source for information as it comes out, the attributable risk from physical inactivity was about 9% of the risk of being hospitalized. So not insignificant. And others have subsequently replicated this work. Two beautiful studies in the British Journal of Sports Medicine, which show that being consistently inactive is certainly associated with an increased level or risk of hospitalization. And roughly speaking, if you're very inactive, it's equivalent to approximately having poorly controlled diabetes and an HbA1c above 8%. And so a message that started to emerge within the general media and in the scientific media, suggesting that regular exercise may help protect against some of the more severe consequences of COVID. And then some data emerging last year that suggests that being physically active may actually modulate the time course and the types of symptoms that you develop when you do get COVID. So I hear you thinking, so far so good, fantastic. If you're an athlete, you must be entirely protected from this novel infection. And yet, at the same time, it was becoming increasingly apparent that some of our very best athletes, those at the sort of prime and peak of their physical conditioning, were struggling with protracted symptoms, which were really scuppering their chances to return back to the levels of sport that they were achieving at, and really, frankly, scuppering their chances to go to the Olympic Games. And you see two relatively famous athletes here who've talked a lot about the prolonged recovery that they've had from their COVID symptoms. In the general population, as I'm sure you've heard a lot about already today, and I'm sure you will again tomorrow, more and more data was coming forward in terms of describing time duration of symptoms and the prevalence or characteristics of individuals with so-called long COVID. This is one of my favorite pieces of work from the Zoe tracker app and published in Nature. Self-reporting apps that I'm sure many of you will be familiar or used yourselves. And they took a cutoff at 28 days. They found that about 13% of individuals were still symptomatic at 28 days from the onset of their symptoms. And you can see over here how this was more prevalent in individuals over the age of 50. I think it's fair to say, although the definitions of prolonged or long COVID have changed and altered over time, that anyone who's symptomatic after from a viral respiratory tract infection is a prolonged time to be unwell when you consider it in the context of other respiratory tract infections that we would encounter. The other thing I would just want you to park in your minds for later in the talk is that these figures are influenced by age. And when I speak to this group in a personal communication about the prevalence of long COVID in individuals of the age range under 30, the figure is actually closer to about 5%. So at this point, we still didn't really know what was happening in the athletic world. And fortunately, Martin Schwellnus here, shown on this webinar, I was on with him from Pretoria, set up this study called the AWARE study, which again used a sort of mobile phone tracking questionnaire type system to try and see if we could obtain some information about the types of symptoms that people were getting, not only with COVID, but also with other infections. And these were self-proclaimed athletic individuals. And as you'll see from this graph here, from this table here from the later publication that we put out in the British Journal of Sports Medicine, that about a third of these individuals were classified as professional or elite sports individuals. And you can see that the numbers included in this study, which was one of the first of its type, were very small, perhaps in a rush to get some information out into the public domain, and only 45 individuals were included. And what we found was that this is deliberately small, just to show you the sort of spread of symptoms that we looked at. But the take-home message was that the symptoms in the athletic population were actually very similar to those symptoms encountered in the background population at that time. And we were starting to see that there were clusters of certain types of symptoms that appeared to be associated with a prolonged chance of what's called not returning to play, which means returning fully back and getting back to sport at 1 month. And these were symptoms such as fatigue, fever, difficulty of breathing, and chest pain. But what about the very elite level end of the sporting arena, the sort of, if you like, the finest specimens of individuals undertaking physiological endeavor? And we undertook this study because I was helping Team GB and the English Institute of Sport in preparation for the Olympic cycle and optimizing their respiratory health. We undertook this study to see how had COVID affected all of the athletes within this funded and very closely medically monitored cohort of athletes. And we published this paper in the British Journal of Sports Medicine again. But you can see that over this time of the first and the second waves in the UK up to approximately a year ago, we had 147 so-called international level athletes preparing for Olympic or Paralympic competition who were able to analyze the duration of their symptoms and characteristics. First thing to say is that all the athletes had a relatively mild, or perhaps a few had a moderate disease, none required hospital care. Most were able to continue with their activities of daily living. And the median duration of symptoms was about 10 days. You can see over here as well that symptoms lasting for longer than a month were present in about 14% of individuals. If you recall back to the Zoe tracker app data that I showed you, and we overlay the histogram from that study, you can see that actually it's pretty similar actually when you stack up these numbers into that figure over 28 days. Bearing in mind this is a much younger population than that study in the Nature report. The other thing to say was that nearly all of the athletes had returned back to feeling asymptomatic by 90 days. You can see that that figure was 3%, offering some hope or a light at the end of the tunnel for those who were still struggling after 28 days. The other thing, of course, we were very interested in within this setup was how long was it before athletes felt fully signed off and back to be able to perform very vigorous training and to compete in their sports, a key metric, as you can understand, for the type of population that we're looking after. And this has a much more sinister look to the figure, where there's a really quite a long tail on this figure. And you can see here, there was actually 1 in 4 athletic individuals who weren't fully signed off at a month of being back and fully available to sport. Now, the logical question to ask is, well, how does that compare to any historical data you might hold for non-SARS-CoV-2 infection? And within this monitoring system in the English Institute of Sport, we're very lucky to have some of that type of data for other typical pre-pandemic respiratory tract illnesses. And what you can see is that actually, as you might expect, for the vast majority of athletes, it has no impact on their ability to continue to be fully available. And there's only a very few individuals, in fact, 1 in 20, who don't feel as though they're able to be fully signed off and back to sport at 28 days. So then begs the question of why is it that people are struggling to get back after sport? And we try to look at clinical clusters to see if there's anything that in the initial presentation that would identify individuals who are struggling to get back to their sport. And we clustered symptoms by whether they were present in the lower chest, so breathlessness, or whether they were confined to just being in the upper respiratory tract. This is a historical way of approaching medicine called the neck check, where you say to people, if your symptoms are above the neck, you're probably okay to continue. Below the neck, you need to be much more cautious. And in fact, we found that that was the case, really, that individuals presenting this lower respiratory tract phenotype were far likely to be back at compared to those with symptoms confined to the upper airway. So what's happening? Because people are asymptomatic, there's a figure of only about 13%, but there's 27% who aren't back to sport. And we know from some studies and more that have emerged since this time that certainly this illness has a immediate knock-on effect on physiology and ability to perform sport. So here's some data from some elite handball players, only a small number of individuals available, and again published within the Nature series. And you can see the impact of some of the measures on cardiopulmonary exercise testing in terms of the cardiac response to exercise and some of the ventilatory responses. And I know that Ronan Aston's going to talk a lot about cardiopulmonary exercise testing tomorrow, so I'm not going to go into this in depth, but it may explain why physiologically people don't feel back and fully available in their sport, whereas symptomatically they feel a lot better. The other key driver at this time, of course, was that there was great concern about whether COVID could cause myocardial inflammation and damage. And in fact, early data emerging from some centres across Europe especially suggested that young, fit people had a 1 in 4 chance of getting myocardial inflammation when you put them into an MRI scanner and looked at things like edema in the time following their COVID infection. Very scary indeed, and of course leads to reticence and reluctance to return an athlete to full sport for fear of potentially inflaming and damaging the heart. Now, of course, since this time, we know a lot more about this. 2 fantastic studies with large data sets from the States. Here's one for 800 athletes. Here's one for 3,000 athletes, published in excellent journals like Circulation, which have subsequently shown that their risk of myocardial inflammation is far lower, probably less than 1 in 100. And in fact, for those athletes who have got a myocardial inflammatory signal on cardiac MRI, they've nearly always got some degree of symptoms or cardiac localizing features at the onset or presentation, and certainly if not, then when they return to exercise. So it shouldn't be a surprise to you to see that when more recent data has emerged about how athletes in different parts of the globe are recovering from COVID, and this is a data series again from the States and from John Dresner, again, including very big data sets, much bigger than the data set that we studied, we're starting to see that a slightly different picture emerge. Now, in this latest publication, you can see that actually the symptoms have changed slightly from when we would have seen, we're far less likely to see changes in taste and smell at the first wave in the UK, but these are prominent features in this data set, which is a slightly later data set. But you can see, most importantly now, that the prevalence of prolonged symptoms lasting longer than 4 weeks is far lower than the figure that we reported, now only at 0.8% or 40 individuals out of the 3,000. And more so, the symptoms that are persistent at that point are symptoms which are not likely to cause a lot of problems because they're things localizing, for instance, to the upper airway. It's again a slightly different story when you then look at individuals going back to their sport and seeing whether they've got some limiting factor which may impact their ability to be fully signed off. And you can see that the figure is slightly higher, nowhere near the type of figure that we encountered at 137 out of the 3,000 individuals. And the key features is shortness of breath and chest pain, But it's very reassuring to see that when you put those individuals through a number of different tests, including, for instance, cardiac MRI, other types of tests, CPET testing, generally speaking, as you'll see, most of the tests reveal a normal finding. So a story that tells you a journey of understanding, a journey of being slightly nervous potentially, that's influenced some of the data that we get and needs to be interpreted with a little bit of caution. But what do we still need to learn? Well, I would argue an awful lot. At the ICH in Tottenham Court Road, as part of UCL, we've been undertaking a study and seeing athletic individual clinical service to try and get a picture on what are the main features and what do we find when we undertake series of investigations to try and reinsure athletes. To be clear, this is a clinical service, and so the first thing is to say, look, we're going to do the tests, which we hope will reassure you that there isn't any pathological process causing your ongoing symptoms. But in nearly 90% or more, the tests are incredibly reassuring. And the main 3 symptom patterns that we see for people being referred, athletes being referred to this clinic, are unexplained fatigue or a failure to recover, so they feel exhausted all the time, an inappropriately high heart rate response to exercise. You heard in the previous talk about features of autonomic dysfunction, and the heart rate response is a key feature of that. And then a feeling that you can't get a breath in or difficulty catching your breath. This isn't a particularly new concept. So if we go before the pandemic, and for many decades, really, people have been very interested in so-called fatigue in athletes or unexplained underperformance. Some have called it the overtraining syndrome. There's a huge number of hypotheses put forward to try and explain this type of phenomena, including endocrine issues, abnormalities or dysregulation in mitochondrial function, immune dysregulation. And I think my honest conclusion at this point is that we don't have any strong pointers to indicate one of these particular features being the sort of forerunner, and it may well be that it's a composite of various different dysregulated pathways which drive this type of fatigue that we're seeing in athletes. We've been undertaking a lot of cardiopulmonary exercise testing, and we've been looking for features of either peripheral or central issues, and particularly issues with breathing control. And so if you think back to one of the key features that I described was that individuals struggling with difficulty obtaining a satisfying breath, I've not found in athletic individuals evidence of dysregulation in either airway function or problems with the pulmonary interstitial interface when you look at measures such as gas transfer. But what I have found a considerable amount of is dysfunction or dysregulated breathing patterns. And so here you see on a cardiopulmonary exercise test, increasing intensity, and you see the highly erratic tidal volume that's very high in early exercise as an athlete feels that they can't obtain a satisfying breath. And I know others are going to talk a bit about that on the conference. So listen, I'll close there and I'll say a quick run through, and I look forward to the chat at the end of these 3 talks. But COVID does impact athletes and does have a significant impact in many ways in terms of getting athletes back to their former abilities and their capabilities to compete at international level. We have encountered pre-pandemic, and there are far more specialist clinicians who spend their time looking after athletes with prolonged fatigue or unexplained underperformance. We still need to learn a lot about how COVID influences this, and as our COVID restrictions settle down, there's still an awful lot to learn that will be useful for other viral infections and their impact on athletes. And I will stop there. Thank you, Hugh.
James, that was absolutely tremendous. Thank you very much indeed. Again, I've got pages of notes here because I'm really enjoying the conversations, and there are some themes appearing, which I'm sure you picked up as well from Oliver and with your work as well. So we'll explore those in due course. And actually, of course, some of those common themes relate to ventilatory regulation and ventilatory function as opposed to respiratory function, which brings us very nicely on to Melita McNary from Swansea, who's going to address specifically one element of that, which is whether inspiratory muscle training has a role in rehabilitation of such patients. So Melita, over to you, and in 20 minutes time, we'll rejoin for a group conversation. So again, please do feel free to start sticking questions into the chat functions if you wish. Otherwise, we'll pick things up at the end of this session. So Melita, over to you.
Thank you very much, Hugh, and thank you everybody who's here to listen to this afternoon. So as Hugh's briefly alluded to, and in a slightly different tangent to what we've been listening to for the majority of today, this is much more focused on the rehabilitation. So it's less about the characterization of long COVID and more what can we do on a day-to-day basis, and for those predominantly who haven't been hospitalized. So this was a Welsh Government funded study, and I'm just one of many people who I will allude to at the end of the presentation that I'm presenting on behalf of. So we've heard a lot today about the context of long COVID, and it puts many of the comments on this slide slightly behind the times, really. So we know that long COVID is defined by the NICE guidelines as symptoms that persist for at least 12 weeks, and terrifying statistics as to its prevalence at the moment, and calls that it may well be the next pandemic is one of long COVID, with 20 to 40 million people estimated to potentially be affected by this going forwards. Obviously, there's lots of debate about whether or not long COVID is associated with the severity of your acute COVID experiences. But what we were really focused on was, how can we resolve those symptoms? What can we do on a day-to-day basis, as I say, to actually help these people? One of the first steps we did was to investigate by asking those people who have had long COVID what they've actually experienced. And we felt this was important in terms of co-developing our intervention to enable us to address many of their key concerns. And it was very stark when people were describing to us that they literally hadn't been able to make a cup of tea, or they felt like they'd aged 20 or 30 years pretty much overnight. So this really gave us the backdrop that we needed to come to them with a rehabilitation strategy that wasn't going to exacerbate their anxiety, that was mindful of the unremitting but also relapsing nature of long COVID, and hopefully targeted some of those key symptoms. Obviously, we've again heard much about this today, with fatigue, shortness of breath, joint and chest pain being some of the most prominent. We've got much more recent data than this earlier representation, but I think it still comes through that shortness of breath really is one of the most commonly cited, and for many most distressing symptoms that they experience. So moving on a little bit more to what we were going to look at. On this basis of when shortness of breath started to really be discussed as one of the major symptoms, we revisited some of the early work that was done looking at what the effects of that increased worker breathing were. So this is a very elegant study that was done back in the early 2000s, where they looked at the relative effects of loading or unloading the respiratory muscles and on perceptions of fatigue. So you can see on the figures on the right-hand side of the slide here, you've got two different conditions. The one on the left is if we unload the respiratory muscles. So if we take away some of the work, you can see the work rates are matched. So is the duration of exercise. So it's not that exercise is any easier. This is just assisted exercise, if you will. And you can see how much lower the muscle fatigue is relative to the control condition where there's no assistance with the breathing. Conversely, when we then do the opposite and the respiratory muscles are then loaded, so they're made to work additionally hard to meet that same matched exercise challenge, you can see how much harder and how much greater the muscle fatigue is. So this really speaks to why that shortness of breath might be so problematic, why this could be potentially associated with a myriad of the other symptoms that they are experiencing, and spoke to us about why, if we could address that shortness of breath, perhaps we could have wider effects beyond just affecting the respiratory effort. When we tried to think and hypothesize why this might be occurring, we obviously revisited the metabolic reflex and the concept of increased respiratory effort sending signals that ultimately result in reduced blood flow to the muscles and thereby leading to increased effort perceptions. So this seems like quite an elegant, quite a simple potential method of rehabilitating people en masse. Now, when we normally talk about pulmonary rehabilitation, there's obviously fantastic pulmonary rehabilitation programs that are offered through hospitals. These are widely effective across a range of respiratory conditions, and we're by no means denying how effective pulmonary rehabilitation is with its multi-component structure, especially that exercise part, which is so central to it. But fundamentally, this model of pulmonary rehabilitation, whilst potentially highly effective for those experiencing long COVID, is extremely difficult to actually implement to the masses that require it, not least because of its typically in-person, hospital-based and group-based delivery formats, which have obviously been not something that we've engaged in for the last 2 or more years at this point. One of the main issues that has been highlighted is the need for a highly individualized approach to this rehabilitation. So a one-size-fits-all model, a one-size-fits-all exercise intensity is unlikely to be able to help all those who are experiencing long COVID. So on the back of that, we revisited some of the earlier work we had done using respiratory muscle training devices. So this is basically the concept that we can train the respiratory muscles in the same way that we would train your peripheral musculature, by using a mechanical load, by making them work harder and therefore undergo a hypertrophic response. And again, there's good evidence that this works, with good evidence in COPD and various other respiratory diseases, that it is capable of eliciting not just reductions in breathlessness, but clinically meaningful reductions in breathlessness, along with improvements in functional capacity and quality of life. So just to give you a little bit of context as to what I'm actually talking about, this is the specific device and the maneuver that we used. And as our postdoc on the study performs this maneuver, I want you to see how long this is going on for. So this isn't your stereotypical inspiratory effort where it's a quick, short, sharp peak and then you finish your effort. This is what we call through range. So he has to continue breathing in for as long as he possibly can, recruiting all of those accessory muscles and really challenging the musculature to work to its full capacity. So this is quite different to many inspiratory muscle training protocols that are out there. And this is something that we have previously used in other chronic respiratory diseases, so things like bronchiectasis and cystic fibrosis. And this is just a relatively small study, but it was really the qualitative work around this that suggested to us it might be quite positive and quite encouraging. So you can see some really encouraging comments there around how they were able to walk up hills that they hadn't previously thought that they would ever be able to walk up again. And even if we look at individual level variation, everything is pointing towards a very positive adaptation with just 8 weeks of inspiratory muscle training. So we then followed this up, and as I say, we were lucky enough to get some funding to enable us to do this study. We aimed to recruit both controls and intervention people, and we were aiming for 200 people in our intervention group and 50 people in the control group. Those in the intervention group would then take part in 8 weeks of 3 times a week inspiratory muscle training at 80% of sustained maximum inspiratory pressure. Those who were randomized to the control group, obviously many of them were not particularly happy at being randomized to the control group given the time point at which this study was conducted, which was November 2020 through to July 2021. We were actively enrolling people in the study. So those in the control group were then given the opportunity to take part in the intervention after they had completed the control arm. This is the app that we used throughout. So one of the great things about the particular device that we used for this study was that it provided biofeedback to all participants after every single breath. And it also meant that we could remotely track their adherence. So every session they did, every breath they did within every session was automatically uploaded to the cloud. And we have subsequently been able to download that and actually look at adherence and look at our results according to adherence. So we know, is it that the intervention doesn't work, or is it that people don't want to do the intervention, which are obviously two subtly different but equally important outcomes to establish. Now, given the time point that this was conducted through various different phases of lockdowns, the entire study was conducted remotely via Zoom. And during this, we collected measures of breathlessness using the Kingsbury Interstitial Lung Disease Questionnaire and the Baseline and Transient Dyspnea Index. We took measures of perceived competence and quality of life, along with physical activity using a wrist-worn accelerometer. We estimated aerobic fitness or functional capacity using a chest-to-step test. And in a subsample of participants, we asked them to take part in one-to-one interviews to ascertain their experiences of long COVID, but also their experiences of the intervention. As again, that participant voice is vital if we're going to actually develop this into something that can be implemented on a large scale. So here we've got our flowchart that shows the recruitment and retention throughout the study. As you can see, we've got quite a large number of expressions of interest. The entire study was only advertised via social media and emails. So we got quite a lot of interest in a very short period of time, actually closed recruitment relatively early on. We got quite a few people who did withdraw after or didn't respond following the information sheet being sent to them, but we actually over-recruited in the end, and we randomized 281 people to the intervention and control groups. As you can see, the final numbers weren't quite as encouraging, with 101 who completed the intervention and 37 who completed the control group, and I'll touch on some of the reasons for that a little bit later on. So here we've got our participant characteristics of the people who did complete the study. As you can see, they're very much the stereotypical long COVID population, with the middle-aged and predominantly female. Interestingly, they were quite a long way past COVID, most of these people. Most of them were 9 plus or minus 4 months post-COVID. So these weren't in the acute phase. These were people who had been experiencing this for quite some time by the time they enrolled in our intervention. I should say that these participants did not necessarily have confirmed COVID because, again, at the time point when we were doing this, many of the people who had long COVID at that time point, there was not testing available at the point at which they would have had COVID. So these were self-reported COVID cases. As you can see at baseline, the two groups were well matched on our primary outcome, which was the King's Brief Interstitial Lung Disease Questionnaire. So on to the slightly more interesting side, which is what effect did the 8 weeks of inspiratory muscle training have? Well, here you've got, again, the King's Brief Interstitial Lung Disease outcomes. And I want to draw your attention, first of all, to the total bars, which are the ones furthest to the left. So control is always in red, intervention is always in blue. And you can see that whilst there was an improvement in the control group, which is very encouraging in terms of doing nothing, people will still get gradually better, the magnitude of improvement was significantly greater in our intervention group, at least in part because they had that slightly lower value, albeit not significantly, at baseline. More encouraging overall, though, was this subdomain of breathlessness, where you can see whilst there was marginal, if we're being very positive, improvement in the control group, there was a very large improvement in the breathlessness experienced in our intervention group. And these improvements in breathlessness and chest and psychological symptoms were all well above the level considered to be clinically important. So you can see levels of at least 1, if not double, the threshold required to be considered clinically meaningful. Now, these changes in perceptions of breathlessness were also evident in the baseline and transient dyspnea index, where again you can see matched at baseline in our two groups, and then twice the magnitude of change and twice the minimal clinically important difference was observed in our intervention groups. And these were all really underpinned by some significant changes in respiratory muscle strength. So keeping with our control group in blue and our intervention group in red, we can see 3 different measures here of respiratory muscle strength. You've got MIP, which is maximal inspiratory pressure, FIT, which is a fatigue index score, and sustained maximal inspiratory pressure on the right-hand side here. And you can see in both SMIP and MIP, significant improvements were evident in our intervention group, indicating that these reductions in breathlessness were potentially associated with improvements in respiratory muscle strength. On a more functional level, we also saw a nearly 10% increase in estimated aerobic fitness, improvements in perceived competence, and also in our per protocol analyses, we saw improvements in the time spent in moderate physical activity and reductions in time spent sedentary. So all of these suggest that not only were people feeling less breathless, but that was translating into their functional ability and their daily lives. And this is something that was supported by the subgroup who we spoke to about their perceptions of the intervention, with the majority reporting that their symptoms felt significantly better over the course of the 8 weeks. Obviously, as you can see, for full transparency, while the majority fitted in with the quote at the top, some did say that there was no real change. They weren't any worse, but they weren't necessarily better. And some did say that they had possibly got slightly worse, or that's probably more related to a lack of adherence than necessarily the intervention, I would suggest. In terms of the wider impacts, they reported being able to do activities that they hadn't been able to do for the previous 2 to 3 months, feeling fitter, being able to return to work, which was a vital one for many of our participants, and also interestingly, they felt less anxious. Indeed, many of our improvements were associated with decreased anxiety, according to the Health-Related Quality of Life questionnaires, with the psychological domain of the King's Brief Interstitial Lung Disease also associated with time since COVID, with poorer experiences in those further from their acute experiences. Now, obviously, it's not always going to be effective for everybody, and I think this is really important to highlight, is that there is no one size fits all. So for some people, it didn't work. It did feel like a setback for them. For some, they felt they got better, so they pushed themselves harder, and then they found that the other symptoms were limiting them. So it might be highly effective in terms of breathlessness, but it's certainly not a one-stop to solve all of the many symptoms associated with long COVID. So obviously, one of the interesting questions is, why might we have been able to elicit reductions in breathlessness through this relatively low volume intervention? It's a bit hard to answer this because obviously the entire study was done remotely. So we don't have the measures we would love to have taken if this had been a lab-based study. But on the basis of what we've seen in previous studies using inspiratory muscle training, we would hypothesize that it might be related to a reduced neural drive concomitant with improvements in breathing patterns, which certainly speaks to the previous presentation, all of which led to a better balance between demand and capacity of the respiratory system, and also potentially that improved respiratory muscle strength may have served to reduce diaphragm activation such that a smaller amount of work was required to meet any given demand. As I highlighted a little while ago, we did obviously see quite a lot of withdrawal through this study. There's many potential reasons for this, and unfortunately we weren't necessarily able to get those reasons from the participants, because when they withdrew, they typically declined to then respond to any of our subsequent follow-up. Nonetheless, what we believe is that it might partly be due to the time point at which this was conducted. Many people were so desperate to get some help, to get access to somebody who was going to listen to them, that they would try many things simultaneously. And if one thing didn't work in the first couple of weeks, they would drop it and move on to the next as things became available. I say we had a high withdrawal. We do still have one of the highest sample sizes for any inspiratory muscle training study conducted to date. So this should have reasonable confidence in the results reported herein. So if I was to try and draw this to a conclusion, I think we have preliminary evidence here that inspiratory muscle training does represent a feasible approach to help in the recovery from COVID-19. It does appear to be effective, at least for a majority of the participants. And one of the most encouraging aspects of it was its entirely remote nature. We had conversations with these people to show them how to use the devices at baseline, and we saw them again 8 weeks later. This isn't something that's massively burdensome for our already overstretched healthcare systems. So it might actually represent a truly feasible approach to one arm of rehabilitation for people suffering from long COVID. So future directions is obviously to try and roll this out on a much larger scale. As always, we need to implement it in a wider range of participants. And there's been quite a lot of debate within the team as to whether or not, as we continue to go down this path of COVID and the many different versions of it that occur, maybe we should be offering inspiratory muscle training as a prehabilitation technique for those who are at most risk of severe outcomes should they contract COVID. So with that, I'd just like to acknowledge the much wider and much more intelligent team who are part of this research, and say thank you very much for listening, and I'm happy to take any questions in the panel that follows. Thank you.
That was wonderful. Thank you very much, Melita. That was, and thank you to all of you for spectacular timekeeping, because normally there's a bit of mission creep, isn't there, moving onwards, but we're in 3 minutes under time. That gives us a little more than 30 minutes for questions. If we're done before, don't worry, we're not going to prolong the pain. But I'm looking at the Q&A chat live, so if you do have a question, do please put your questions in. And there are a couple in there as well, but let me just start off perhaps with some questions. To all of you, the one obvious one, of course, which has been discussed before, we've got a shifting baseline here, haven't we? We've got a bunch of people who got hit with mu, then alpha, then delta, now Omicron. So some people have had more than one hit. People now having Omicron are not getting the viruses we had before, and their patterns do seem different. And we're dealing with people, a survivor bias, but also a change in vaccination. So where do you think we sit now, given that we've got historical data? And that's not in any way to denigrate the work that you've all done, but what do you feel about the applicability of this in the modern disease context? Does anyone want to pick that up to start with, or are you all going to duck?
Maybe I'll start from an athlete perspective, Hugh.
Yeah, please. Yeah.
I mean, I think that's very, very relevant and of interest. And I think, as you quite rightly say, certainly my experience that this is a very different illness than for maybe one of all of those features or those features combined in the way it's affecting people. I mean, I think what we need to take from this now is the fact that a lot of the condition or the syndromes or the symptoms or have been relevant pre-pandemic and in other viral infections. So the huge amount of scientific investment and scientific endeavor that's been undertaken over an incredibly short period of time, when you consider it, I think will have immense value in terms of translational benefits for how we deal with all sorts of so-called post-viral or unexplained type syndromes. And I think, you know, that's what we need to really lean on. So same probably for the military, I would have thought, and same for, you know, whether inspiratory muscle training can help in those other types of scenarios. So whilst we are seeing this sort of slip away and hopefully fade away a little bit in terms of the intensity of these symptoms and the influence of vaccine being so beneficial, there's still a lot to have been learnt and still to be read out from the studies that have been done to date.
Yeah, I'd agree with you, James. Yeah, please carry on.
So I think from a defence point of view, what we've been keen to do is share our knowledge and not hold it centrally at the DMRC. We act in a kind of pyramid with a tertiary referral centre, and we've got kind of tiers of rehab below us. And what we're keen to do is arm those more peripheral centres with the ability to rehab people, give them what they need at the point that they need it, rather than waiting to see us and the delays that ensue there. So we're hoping that more link with primary healthcare will allow what we've learned and the things that we've seen to be effective to be utilised by clinicians further forward, if you will. And so for us, that's been a real positive. Increased, you know, up and down, left and right interaction means that patients who need it get the care sooner and get it in a more convenient location.
Yes, well, thank you, and I'm agree, and I think probably what we have to do, of course, is always keep our eye on the ball and keep getting the phenotypic data, don't we, to see, to make sure that we are dealing with the same disease. I'm going to move on because we've actually lots of questions coming in, and I'm going to pick them in some sort of order if I can. I'm going to ask a question I was going to ask anyway, which was to all of you about your experience of patients with asthma, because I, of course, only looked after intensive care patients, but it was quite peculiar that we never really saw asthmatics getting very tight airways when they hit the ventilators. They often had, you know, they had nasty COVID lung, but they didn't seem to have severe. In fact, we've got quite a few patients who reported to us that they didn't realize they were in trouble because their asthma got better when they got COVID and they were using their inhalers less. And in fact, I've got a couple of patients in the follow-up clinic who say that they don't really have significant asthma anymore, and they were very bad asthmatics prior to this. So that's all anecdote. And there's a question in the chat function here asking the same sort of question. What about patients with asthma? How were they affected? Did they do better or worse? Do any of you have any experience of those?
From our point of view, the military. Oh, sorry, James, after you.
Yeah, go on. You start, Oliver, and then we'll go to James. Oliver.
So obviously the military population is generally pretty fit, although we do have chronic disease. So we do have patients with asthma in the armed forces. And what we saw, there wasn't really a difference. Those people who had asthma, which was a very small proportion, fared equally. So I suspect that probably it may have been even protective given the very small numbers that we saw, but it wasn't enough for us to change our pathways for them.
Yeah, it's interesting. So, because of course there's a potential bias here, isn't there? Which we didn't seem to be hearing, that the people who were using inhalers, might be Becketide, were relatively protected. But actually, we were hearing people saying, "Well, it was a bit weird. I thought I was doing fine because I no longer needed my inhaler." James, what was your experience? Then we'll ask Melita as well what hers was.
Yeah, I mean, I'm involved with a severe asthma service here at the Royal Brompton. And as I said in the sort of talk, we were sort of preparing ourselves for, you know, a pretty devastating impact of this illness on our population that we look after, and that wasn't borne out in reality. Surprisingly, as you say, because people would think that if you were vulnerable and if you had severe asthma, you'd be particularly vulnerable, and the data hasn't really borne that out in a variety of different studies, many published in the Lancet Resp. Of course, Simona Bafadell's study looking at budesonide seems to indicate there's a protective effect of budesonide, and I'm sure there's a scientific rationale and the way that steroid can affect the receptors and the ACE. In fact, you'll know a lot more about that than me, Hugh, but those things are likely to be relevant. I mean, I think the other thing to say is that if you look at the physiological consequences post-COVID and look, for instance, at a series of lung function data in those who have been hospitalized with the condition, this is very much a pulmonary interstitial insult. Yeah. And there's very little signal to suggest that you get an airway-centric signal. Generally speaking, FEV1 is preserved. There aren't obstructed ratios. And in athletes, although there's a couple of anecdotal type reports of airflow obstruction in post-COVID cases, by and large, in my experience, that isn't the reality. It's been affected by this condition.
Interesting. Yeah, that would match with, I guess, our anecdote. Melita, did you have any experience of asthmatic patients that you saw in your studies?
Not especially. We did obviously ask if there were any contraindications or anything we needed to be aware of prior to their participation, but no one was really raising that they had a particularly severe asthma status when they were enrolled. The few people who did mention it were certainly equally distributed amongst those who did and didn't demonstrate the biggest changes. So I don't think it's a predictor of outcome from our study.
Thank you. Moving on again, picking out some themes here as well. The issue of ventilatory drive, of course, and ventilation overall was an issue. We always had the happy hypoxia story to start with, of people chugging away and seemingly unaware that they had minute ventilations of 60 litres. So I was going to ask James first and then come to the others. You mentioned, or was it Oliver that was mentioning, the ventilatory efficiency? Oliver, I think. And you said there was some evidence in some patients of ventilatory efficiency impairments. So my question was going to be, in that percentage, was that a change in ventilatory efficiency for what? Was it a VVCO2 problem, or was it a VVO2 problem in terms of those that suffered ventilatory inefficiency? And what conclusion did you draw from that?
That was something that I was reporting, so I'll go first if you don't mind, James, and then if you go next. So we used the VVCO2 slope as our marker, and we felt that the two most likely causes would be there would be some lung pathology impairing the VQ, or there'd be some inappropriate ventilation. So our first thing was to check out the pathology. So we looked at the cross-sectional imaging and we looked at gas transfer, and we didn't find much correlation. So then we wondered if there's some inappropriate hyperventilation, and we did point of care and end-tidal CO2 on capillary blood gas testing, and we didn't find the expected change. We didn't find an increase, but there was an increase in breathing frequency at rest in VT1. So our feeling was there was an inappropriate ventilation pattern there, but we wondered if it was perhaps anxiety driven. So we looked at the patient reported outcome measures that we were looking at, GAD-7 primarily, and there wasn't an association there. So if there is some ventilatory inefficiency because of inappropriate hyperventilation, we wondered if it was a central cause rather than an anxiety driven or conscious effort. But I'd be really interested in other people's opinions of that.
Yeah, I'd be interested to hear, and James, then we'll come to Melita too, because obviously if you've got a VEVCO2 problem per se, then one prospect is you've just got an increase in physiological or anatomical dead space. And the other is that you've got there's an element perhaps mixed in with that of the central drive issue, and which comes to Melita's issue too. But James, yours VVCO2 slopes and stuff tend to suggest that you just got a hyperventilation rather than an inefficiency per se. Would that be right?
Yeah, I mean, as you say, that the measure that you look at it's interesting to me how you look at that relationship. If you plot a continuum right across the exercise bout and then try and take a gradient, or whether, as I tend to do, is to look at a nadir of that the equivalence of CO2 during an exercise bout, and then just, I think, either which way. I mean, if it's high, then as you say, you've either got a problem with, in my experience, the dead space, which is speaking back to the pulmonary vascular interface, or you've got a low PaCO2 set point, and it suggests from Oliver's data that isn't the case. And in our findings, most of the problem is being a tachypneic breathing pattern, which is associated with an increased dead space, because for each breath that you're taking that extra additional dead space, which is not partaking in gas exchange. It's just being moved inefficiently in and out of the central airways. I don't know. I mean, I'm not aware of any studies, and there may be some who are attendees who know this better than me, that have looked at actually drive and official drive studies looking at, for instance, responses to CO2 loading or that type of challenge and hypoxemic challenge to see what the drive response is like. But those would be fascinating to know about, and please enter in the Q&A if you're aware of studies like that.
Yes, thank you. And so Melita, there's lots of chat appearing on the business of inspiratory muscle training. So could I just ask you the obvious question, which you did allude to start with, that how easy is it to draw conclusions from a study such as this? You lost around 37% of your controls, but you lost 180 out of 281 of your treatment group. So you're likely to have retained the people who, for some reason, felt they were getting benefit from that. And that doesn't necessarily, of course, mean that it was the treatment that made them better. They could have been the people that were improving anyway. How confident are you that it was the intervention that was making the difference, not the survivor bias effect?
Yeah, that's a great question. Obviously, something we've wrangled with a lot. It's how can we, in such a remote nature, what can we attribute it to? And we've obviously got the adherence data. So we can see that these people were doing the training. They were doing it at least 2 times a week, in the majority of them. And we can see throughout those sessions, the progressive improvements in each of their efforts. So something is definitely happening. I think there is undoubtedly going to be a component of it, which is the psychological element of they felt they were doing something. They felt like they were taking control of their condition. It gave them more confidence to go and do other stuff that they had given up on doing because they felt they were going to have a relapse or an exacerbation. And therefore, they did get benefits from the wider remit of their daily lives by that point because they re-engaged with them. Obviously, talking about the breathing pattern elements, the big debate we have is have we effectively retrained them to breathe? So have we taught them again to take big breaths, to recruit all the appropriate muscles? Or have we fundamentally just strengthened the muscles, and then we've just strengthened muscles with no real translation into physical and daily lives? But I think the functional measures that we took do suggest that this isn't just something that trains your respiratory muscles and has no knock-on effects into real life.
Is it not just possible that the 180 people who, let's say, didn't get any better or getting worse dropped out because they just thought, I'm not getting any better, and it left you with a bunch of people who were self-selected to be getting better anyway?
Yeah, it wasn't 180 people that dropped out of the intervention group. So there was 180 people that dropped out. It wasn't even 180 people. There was my maths isn't fast enough, but about 140 people dropped out in total from both groups.
I just thought you were 281 going to 101, but that might have been.
It was 281 randomized into 111 in the intervention and 37 in the control group. So it's not great numbers by any means, but it's not quite that bad.
Yeah, but still impressive. And we've got questions in there about which I guess, I mean, you are the expert in this. So the questions are coming down to would prehabilitation benefit such patients? And also, would there be benefits to both inspiratory and expiratory muscle training? And you did touch on that, actually, that the part of the burden of breathlessness being that increased inspiratory load. But perhaps you'd like to touch on those benefits of prehabilitation and also of inspiratory and expiratory muscle training.
Well, in terms of the balance of inspiratory and expiratory, it really comes down to what the specific purpose is. So perhaps for the military and for the athletes, then there might be a greater role of looking at combined inspiratory and expiratory muscle training, given the greater respiratory efforts that those people undertake. For your average person, obviously expiration is a passive process. So we don't typically in our daily lives need to recruit all those muscles that enable us to expire at those greater forces. That's the reason why we chose to focus more on the inspiratory efforts. I've forgotten the other part of your question, I'm afraid, Hugh.
Well, that was fine. No, there was a question about really about whether if you've got a good respiratory muscle training before, whether that's advantageous to your outcome from the COVID if you already start with good inspiratory muscle force. That was really the question, I think, in the chat function.
I think that probably needs to be passed over to James and Oliver, who have had people with the much higher levels of fitness before they started. I think ours were your average population who perhaps weren't in that boat, the majority of them.
Well, it's a good question, actually, because, again, it's touched on in some of the other questions to you, Oliver and James, which is this issue, which I think does touch on it. Being physically fit, I think everyone on this call will buy into, is generally a good idea. I guess it's possible that having better respiratory muscle function because you've loaded the muscles is advantageous to you as well. But I guess it also brings us this question, doesn't it, of immunomodulation, which you touched on, both of you, about whether being physically fit improves your viral load and response, and indeed whether active physical training when you're infected or in that immediate period afterwards improves outcome. And of course, there are a lot of rodent data to say that both those things might well be true. But where do you sit on that for both of you? Is part of the advantage of being fit and healthy because you've got robust respiratory musculature and so forth, and therefore your sensations of breathlessness and so forth improved? Or is this actually because you're immunomodulating and you're changing the nature of the disease that you get? In other words, you fit gym bunnies, do better than us elderly couch potatoes? You want to say that first? James, why don't you go first, and then Oliver?
Wow, I mean, what a difficult thing to try and unpick. I mean, my general advice when I see athletes is that and this might be a sort of slightly outmoded or outdated view of the world, but I don't generally find that respiratory muscle weakness limits their ability to perform. And I would think it's probably true for most things that they encounter. So I'm probably going to be, trolled now by various people supplying inspiratory muscle trainers. But generally speaking, I don't see it as the key limiting factor in exercise performance. It's a different population or a different potential scenario if you see people who are weak and have been on a ventilator or been hospitalized, and clearly you're coming from a different end of the spectrum. It's very difficult to study performance benefits, isn't it, at the very top end of or athletic endeavor. You're talking about marginal gains that mean the difference between a first or a third place or whatever, which is incredibly difficult to measure physiologically in a laboratory. I think from my point of view, the benefit of the fitness has to be in terms of your subsequent consequences from COVID. I mean, it's clearly going to be a number of different things, including the fact that actually you're likely to be associated with a lower BMI. You're likely to be someone who adopts other more healthy lifestyle issues. I mean, most of the data comes from epidemiological cross-sectional studies that have looked at, big data sets, for instance, in Korea, with people self-reporting the amount of activity they've done. So I don't think we have really any ability or answer or data to be able to say, look, there is evidence of a low CRP value or some other immunomodulatory type thing. But I don't know. I'll be interested to see what Oliver says about that.
Well, I was going to say, so I'll ask you one question, then go to Oliver. So I suppose sometimes when there is doubt, and there is in the scientific literature about what's best, the way to ask you to really distill it is, what would you do? If you were to get COVID, would you rest up and wait? Or would you think that you could improve your outcome by taking exercise? What would you do that?
To that question, if you complete rest of 10 days after the onset of the symptoms, and they were free for 7 days before they returned to exercise, we've moved a long way from that. And I was chatting to Sanjay Sharma, one of the sports cardiologists, about this, and there is data that suggests that individuals who engage in light to moderate exercise early into influenza infection appear to do better than those who don't. So I think there is some data to suggest that early into other viral infections, the early initiation of exercise, and we know observations of COPD difference, people in a hospital bed doing nothing for 7 days, they do worse in readmission rates and their own independent functionality at, say, 2 to 3 weeks following discharge than those who are engaged early in some form of physical activity. So my short answer would be, and the way that we've changed the return to play guideline to the English Institute of Sport is that probably 48 hours is the appropriate time to run COVID. Thereafter, if you're localized to your body, it is to do some light to moderate intensity exercise and then build that up, providing you don't get episodes of chest discomfort or other features which might be red flags of something more serious going on. So I think yes, to exercise early when you develop COVID. And red flags that would indicate you should otherwise be a bit more cautious.
Good stuff, James. Oliver, would you concur with that?
Yeah, it was quite a lot to unpick there, actually. I think if you look at cardiovascular respiratory fitness as a protective measure, first off, I think that and lean muscle mass probably are protective. There's a good Swedish cohort study of recruits who then look at them over time, and if you were fit at one point in your life, then it seems that you do better. In terms of early return to exercise, that's interesting because we went for quite a safe approach in the beginning and kind of said, give it 2 weeks and then see how you get on. Looking at the same data set, I think referred to by James, that he was talking to his colleagues about, we felt that low MET activity, so, you know, a light walk or a light jog, yoga, things like that might be good in the beginning because of these protective effects of exercise, of course, but not going too hard, too fast. So a kind of start low, go slow. And I think over time, that has been the approach that many people have pragmatically taken, which I think is supportive. I wondered in the beginning, 2 summers ago, if some of the people that we saw who were ultramarathon or triathletes who frankly are not sick people, and they refuse to let themselves be sick by virtue of the activities that they do. They used to push themselves beyond. I wonder whether we saw a slightly higher proportion of those than you would have otherwise expected, who just did not allow themselves time to recover and then had lingering effects afterwards. So we're basing on a kind of symptom titrated physical activity return, listening to how you respond and then reining back or increasing as appropriate, depending on your initial symptoms and your initial severity, of course. But I think giving yourself some time at the beginning to get, you know, over the symptoms and then starting at a low MET and then increasing accordingly, or if you feel you're able to kind of go, you know, a slow jog and then going back into your routine stuff.
Okay, we've got another 9 minutes to go. There's an interesting question about whether we're measuring the right thing. So there's a question saying, look, we're getting lots of normal tests, but that might not mean that things are normal. It might be we're not measuring the right things. And there's a question really about some of the microthrombi being missed, for instance, in some of the tests we do. I guess that's alluding to that Nature paper about the synchrotron analysis, showing that actually if you take lung, you can find that a lot of people have got microvascular thrombosis. You just can't find using conventional CT. So there's the question. Are we doing the right tests? Do we feel that we've adequately phenotyped these people, or should we be digging deeper? Melita, do we start with you, and then we'll go to the others. Do you think we've got it nailed now, or do we still have a reason to be drilling deeper?
In answer to this, I'm going to totally diverge from what the topic actually spoke about. So in terms of my exercise physiology response, I would definitely say we need to dig deeper. I think we spend far too much time looking at maximal responses. We need to look at the submaximal, the things that actually dictate our daily ability to move and to function. So we need to be looking at the dynamic response. We need to be looking at the VO2 kinetics, oxygen uptake kinetic responses, which are far more sensitive to positive and negative changes, and are the ones that actually occur to allow us to do our elite sporting activities, our military activities, or our day-to-day activities. So yes, I would definitely say we need to dig deeper.
Well, good for you. And I have to say, I'm an advocate for this because, you know, this is an audience of physiologists. Some of us are practicing clinicians who do that, and I'd like to think we're also physiologists. But, you know, there are so many clever brains out there in the world of physiology, and particularly in exercise physiology. And we really welcome all of this audience's input to these sorts of problems, because we clinicians are sometimes a little blunt in what we do. James, are we blunt tools? Or
we are. I mean, we are. I mean, a patient before this who was referred to me with long COVID, completely fit and well, had COVID, now comes up really struggling to do everyday activities. Has been told by various people that, you know, something in their head, and you know, they just need to get back into exercise, and yet sits there with a heart rate of 130, completely at rest, no reason, no drug cause for that, stands up and tries to walk on the spot, and the heart rate goes up to 170, and yet the tests have all come back as normal, and the carbon dioxide somewhere like 2.6 kilopascals. So you know, you can't tell me that there isn't tests that we still need to find in order to characterize the problems that are really affecting people in this hugely impactful condition. And I see many hospitals like that each month, really, who are debilitated. The thing I would say, caution and control in the way they reported. So if someone goes on a national TV program and reports their test, which has identified 42 people and to markers of lung function or to dyspnea, and makes a big deal out of it as the test that people should have to answer their questions, and that makes it very, very difficult for clinicians on the cold face who are trying to see and help people, demanding access to that given test. And yet the test, as we know, hasn't been studied in a formal way or actually shown in the types of scientific endeavor that would need it to prove its efficacy or its value. So I just think there's a balancing act to be found. And, you know, I'm constantly struck with many of my consults being taken up with discussing the latest serum rhubarb level, which actually I can do nothing about. I can't access, and it doesn't really dictate or help patients in terms of moving forward with a management plan. So you can probably see a slight irritation with the types of tests that I'm asked to do. But at the same time, we must, you know, invest heavily to try and understand the type of tests which will give us the answers to what are very, very real and debilitating pathological conditions, frankly.
Yeah, and I'm going to put this one over to Oliver as well, because there's an interesting question from Mike Tipson here as well. This is a sort of Donald Rumsfeld known unknown, in that we do know that these patterns of breathlessness can be influenced and caused indeed by the point at which you're breathing. If you're immersed into cold water, you do the breathing off at high frequency off the top of a very inflated lung, and yet other forms of breathlessness are associated with very different positions, as it were, on the inflation curve. Have you, I mean, I'm not sure you haven't tested this, Vanita or Oliver, or indeed James, but is this something that you might recognize in seeing? Do you think there is something in what Mike's written in the chat function here, that we're dealing with something about where we are in the pulmonary dynamic curve?
Honestly, I don't know. What's wonderful is talks like this where you realize how stupid you are, and you're exposed to other people's opinions. And I've got copious notes of studies that we're now going to go and look at with our data. You know, we've been measuring breathing loops throughout CPETs. You know, we've done hundreds of them. So it would be we can see abnormal breathing patterns, and you know, you can pick out people that it just doesn't look right to your eye. Where that fits in with the pulmonary physiology, I honestly don't know, but it's an interesting area for us to go and look at, because we can see an association. Therefore, is there any interventions with pulmonary rehab and so on that might be able to improve that? So for me, I don't know, but I'm going to go and find out.
We're down to 2 minutes 26, so let's see if we can rattle through some very quick ones. IMT, role of IMT in management of athletes. Anyone want to pick that up?
I would say it depends entirely on what athlete you're talking about. There's been a huge amount of research done about how good IMT is for athletes, and I think it's a pretty equivocal conclusion, really. I think it's pretty much sport specific, I would have to say.
Okay, that's two of those. Antihistamines. Now, of course, that is an issue that's been raised. There have been a few hints that antihistamines might help people. I guess that fits with some of the mast cell studies, or the hypothesis, I would be more. Anyone got any views on antihistamines? Yes, no. Oliver, yes, no to a trial of antihistamines in long COVID?
I'm going to see what the data says before we start doing it in defence, I think.
Yeah, I mean, and there is a trial going on. Vanita Irving is part of that, with the long COVID trial that you said. So my personal feeling is it's not proven yet. James, your view on that?
Same thing, really. I mean, it's as we've seen right throughout this pandemic, wonder treatments arrive, everyone adopts them, and then, you know, a trial comes out with a randomized and decently powered study, and it's actually hasn't shown anything at all. So if there's one thing to learn from this, is not to sort of run after some things that people anecdotally tell you it works, because more often than not, 18 months down the line or a year down the line, you find out that it was nonsense.
I totally agree. In our last 50 seconds, the issue of autonomic function, we've got a J. Physiol paper being quoted about saying high sympathetic efferent activity to skeletal muscle. We obviously know we've got a POTS issue. You've alluded to the fact there may well be autonomic dysfunction. Should we be looking for that more systematically in these sorts of patients?
I think for us, it's a relatively easy thing to just screen the CPET for. Using Jovan, we saw quite high rates. So I think it's a reasonable thing to look for, personally.
Okay, well, look, we're down to 16 seconds, so I am going to draw things to a close because people have to do things. Thank you so much, all of you. I have to say, I thoroughly enjoyed that. I learned a lot. I share your view, Oliver, that the value of these sorts of meetings sometimes is just being exposed to our diversity of knowledge and awareness and opinion and thought. And I've got pages of notes of hypotheses and no answers. So it's been a tremendous success from my point of view. I'd like to thank you all very much indeed. I'd like to apologise to the large number of people who put other questions in the chat function. I think that's just a measure of how much everyone's enjoyed this session. And I'd like to thank the Physiological Society for organising this. And I, speaking as the bunch of us who are medical on this call, we really do have to start working more with physiologists. You've got such a greater understanding than many people who just go through medical school have. And we really like to work with you. We've got a huge number of patients with problems, and you've got ways interrogating the physiology of those patients, which could be of huge value. So I'd like to thank all of the non-doctor type physiologists on this call as well, and say, please do engage further. And with that, I wish you all a safe evening. Don't get COVID, don't get blown off your feet. And we look forward to seeing you again tomorrow morning. Thank you very much indeed for joining us.